Good evening, friends. Um, I am Dr. Dipak Dave, along with my colleague Dr. Dhanasekara. On behalf of the Education Committee of the ISHKS, our President Dr. Indrajit Sardar, Managing Trustee Dr. Vikram Shah, Executive Board members, our Secretary Dr. Leo Joseph, and all other colleagues, we welcome you for this 13th ISHKS teaching program. Um, Like every time, we have a hip and knee session, and this time the first speaker is going to be Dr. Narendra Vaidya. He's a very eminent uh, uh, arthroplasty surgeon from Pune, and he is the chairman and founder of the Lokmanya Tilak group of hospitals in Pune and Western Maharashtra. And doing this is a large volume center, 50% of that which is robotic, and they do quite a huge number of surgeries every year. He has quite number of fellows and trainees under him, and we are happy to have Dr. Narendra Vaidya with us for this teaching program. His top talk is going to be on the revision TKA in PJI. So uh, he's going to talk about the one stage or two stage revisions in prosthetic joint infection. Once again, with this introduction, I welcome Dr. Narendra Vaidya from Pune. And as I said, on behalf of myself and Dhanasekara and our whole East Executive Board, Narendra, we are thankful to you for sparing your time and coming live onto this teaching program. So over to you, and we'll be requesting you to, after your talk, there'll be some questions from the our colleagues. So please be there to reply on that. You can share your screen now.
Yeah, thank you, Dr. Dave, sir, and thanks, Ishq, for inviting me for this particular topic. So you can see my screen.
Yes.
Yeah. So thank you to all the ISHK members, and thank you to the managing trustee Dr. Vikram Shah, president Dr. Sardar, Dhanasekara, and Dr. Dave. Today I am going to talk about the revision TK in post periprosthetic joint infections. So PJI is a really devastating complication, as you all know, and nobody wants it, but ultimately everybody has to tackle it. Just a minute, I have some issue in my sharing of the slide, so just why it's not moving now. Hey, just a minute. Yeah, so it's a devastating complication. PJI is the most common cause of early failure of total knee arthroplasty. The strategy of management depends on the duration of symptoms, the host factors affecting organism. Duration of symptoms, if it is very early, immediate post-operative period, then the management can be a dire, debridement and exchange of the movable or removable parts, that is the poly component. Host factors are multiple. Patients who are extremely obese, BMI more than 40, or patients who are having diabetes, hypothyroidism can be tricky patients. Affecting organism, MRSA, and other organisms which are having antibiotic resistance, they are also difficult to manage. So there are two strategies which are used for tackling the PJI. I'm not going to talk in very detail about dire because it has only debridement, and it is useful in some cases in a very early stage of PJI when you suspect immediate post-operative period. But for infections of more duration, dire is not useful. So today we'll be covering mainly the two-stage and single-stage revisions. Two-stage revision is a gold standard. It was described way back in 1985. So first of all, we should diagnose the PJI. one of the three criteria must be met. That is a sinus tract, which is communicating with the prosthesis. Sometimes we have only superficial stitch abscess, so that is not actually ideally a periprosthetic joint infection, and local debridement with some antibiotics for 5 to 7 days can be a very effective strategy for wounds or discharging wounds which are superficial. Any wound which is actually draining more than say 3 to 4 days, then you should be very careful in doing that. In such situation, my strategy is to immobilize them for a period. Still it is having discharge, then immediately go in, do debridement, and drain out whatever hematoma, or if there is any signs of infection, that is an immediate post-operative period. If it is a slightly older this thing, then if there is a sinus tract, if there is a pathogen which is identified on culture after aspiration, that is also very important in diagnosis. Or three of the five criteria should be there. That is the inflammatory markers, that is ESR, CRP should be raised. Synovial WBC, which normally should be less than 200, they are elevated. Synovial neutrophil percentage more than 20% is a significant criteria. A microorganism is isolated with one of the periprosthetic fluid, and more than 5 neutrophils per high power field of 400 magnification. So any of these three criteria, then PJI can be considered that the patient is having a periprosthetic joint infection. Two-stage revision is a gold standard. In the first stage, we have we have to do the removal of the prosthesis. We have to do extensive debridement and synovectomy. As far as the debridement is concerned, you have to remove entire synovium as much as possible, all 8 zones of the knee, that is the medial and lateral gutter, the retro-patellar tendon area. Then you have to remove below the quadriceps tendon, go to the posterior compartment. So all 8 compartments or 8 zones of the knee have to be debrided in a cyclic fashion. And you have to develop a protocol of your own and then carefully debride everything. Entire synovium is removed. Whatever biofilm is present, that is removed. Generally, I remove entire whatever area is there and wash it, and again see for any debris or any unhealthy sort of tissue, take out everything. Multiple tissue samples have to be taken before you start giving any antibiotic wash or any antiseptic wash there. You have to take the intramedullary samples also for cultures, and in all the zones you have to take different samples and send it for culture. So that is very important in various bottles. I generally send it to 2 centers at least to have the microorganism isolated. You have to do the reaming of the intramedullary canal. Then you to do antibiotic spacer is injected in the first stage. And now the antibiotic impregnated spacer can be a mobile, that is articulating spacer, or it can be static. And I use calcium sulfate, that is stimulant beads also, along with antibiotics. And then post-operatively, you have to give antibiotics as per the culture of the whatever culture we have obtained. So first stage is to remove the prosthesis. I am going to show a short video because that is very tricky. You have to ensure that there is no bone loss. So I take a very thin saw and close to the implant, you take, cut the cement mantle. You have to be careful on the posterior condyles and see that you don't damage any of the native bone. And you have to rock the prosthesis and take it out very gently. So you can see that we have removed the prosthesis without any actual bone loss. And then you can have the access to the posterior part of the implant also. So I am removing the posterior synovium. After that, then you go to the tibia. For the tibial plate insertion, again, I take a broad saw in the beginning and then cut along the implant and try to cut in the cement mantle, so there is very less bone loss. You can go posteriorly on the medial side quite easily, but the lateral side may be tricky. For that, I make a slight sort of starting with a thin osteotome, and then with a giggly saw, we remove it with a smooth fashion. This is very useful technique when you have to stack the osteotomes, thin osteotomes, so the implant comes out gradually. You can see that without applying any force, you can just remove the implant in a very easy manner. And then you gently, tap it out, and then so you can see there is no bone loss here. So this is very important that you take out the implant without any bone loss. In two-stage, the interim period is controversial, and various authors have described various various period of interim period. During this interim period, you have to consider antibiotic therapies. Again, how many days of antibiotics also is controversial. Some people have recommended up to 2 weeks to 6 weeks based on the clinical progress of the patient, wound healing, and the normalization of the inflammatory markers, that is ESR and CRP. After normalization of antibiotics are discontinued for a minimum period of 3 weeks. You have to repeat the ESR every weekly and see that they have returned to the normal. If these are normal, wound healing is good, and soft tissue condition is good, then you can proceed for the second stage. Again, the timing of the second stage is slightly controversial. Authors have described from 4 weeks to 11 weeks. There are very rare papers where some people have recommended up to 2 weeks after for the second surgery, but generally I wait for about 6 weeks for the settled for the soft tissues to settle. Once that is done, then we can proceed with the second stage. Let's talk something about the antibiotic impregnated spacers. We have some commercially available spacers with antibiotic, but these are prophylactic doses and they don't eradicate the infection. So don't depend only on the commercially available spacers. When you are making spacers, then you have to mix the thermodynamically stable antibiotics in that, and which should give very high concentration locally within the knee joint. The antibiotics used should be thermostable, so amikacin, cefalzolin, ciprofloxacin, vancomycin, and amphotericin B, gentamicin can be used. Antibiotic volume should be 20% of the mass of the spacer. If you mix very less, then it may not be very much useful. You have to again see most of these are aminoglycoside groups, and so you have to also consider about the toxicity and especially the complications like acute kidney injury. So go on monitoring the renal function tests also during this interim period. Articulating spacers have got better functional results in some papers. They maintain a range of movement to certain extent, and the patients are slightly better satisfied in articulating spacers. Having said that, these are some of the examples of articulating spacers where patient will have about 20 to 30 degrees of motion. This is a X-ray of a static spacer where you can see the static spacer in situ with some antibiotic beads put in the intramedullary canal also. These are calcium sulfate and these get absorbed over 6 to 8 weeks time. And so even there is a sepsis in the intramedullary canal also. Indications for static spacers are in cases where there is more bone loss, there is a lack of functional collateral ligaments, cases which require soft tissue reconstruction also should be given a static spacer, and patients who require extensor mechanism reconstruction, if you do a quadriceps nip or you do a TTO, then it is better to use a static spacer. Results are, functional improvement in articulating spacers, but not very significantly high, function in even articulating spacers. The results for infection eradication are same, and there is no significant difference in articulating or these spacers. So the stage 2, as I mentioned earlier, once the antibiotic course is complete and we get an interval of 2 to 3 weeks where normal ESR CRP is there, then wound has healed well, the soft tissues have healed well, then you do the removal of spacer. When you open it, you have to give repeated irrigation. Local antiseptics can be used, and we have to do debridement. And then reconstruction, like any other revision case, you have to do. Keep all the augments and keep all the wedges, augments, everything ready at hands. Sometimes if there is a massive bone loss, you have to keep cones or sleeves also. Always I keep a hinge also at handy, because sometimes if ligaments are incompetent, then you may require a hinge type of revision arthroplasty. If the extensor mechanism is intact and soft tissue envelope is good, then articulating spacers are used as mentioned earlier. So there is no significant difference in infection control as far as these two methods of revision is concerned. Let's again talk about antibiotics, and generally it is 6 weeks of IV antibiotics, but some authors have recommended up to 3 weeks, and then if you don't get a culture, then continue broad spectrum antibiotic. Rifampicin is used quite commonly, and 6 weeks generally is questionable for IV, so 2 weeks is a recommended period. You can switch to oral treatment after that, but before you go for the final implantation in revision, you should have at least 2 weeks of window without antibiotics with normal ESR and CRP. So there is no single investigation which will determine a complete eradication of infection. Compared to primary arthroplasty, assessment of infection eradication is quite difficult. Use of antibiotic can confuse timing of the infection clearance. And currently, there is no universal single protocol which has been described. So as I mentioned earlier, these are the various investigations to see if there is active infection still. The ESR, CRP, cytokinin markers are there. Then WBC percentage polymorphonuclear cells more than 200 is again, per high power field is a indication of active infection. So you have to again wait for that. Sometimes I have done 2 times debridements also. Again, if there is not helping, then you can go in and do a debridement again. Role of irrigation suction is not there in these particular things. Some bone scans, some people have recommended technetium 99 bone scan, but again, not everybody is using it. In 2-stage also, there is high failure rate. Outcomes for a single and 2-stage are comparable. Indications for a single stage revision are limited, and culture negative and MRSA are difficult situations where you have to use broad spectrum empiric antibiotics. Let's talk about single stage revision. The single stage total revision, total knee and PJI is having very limited indications. These are 2 separate, so you should consider it as if you are doing 2 separate surgeries. Even if it is a single stage, then there are 2 surgeries or done one after other under same anesthesia. You have to change the operation theater, change all the instruments, change all the drapes, gowns, and gloves. So it is as if back-to-back 2 different surgeries are done. So that is very important point. If you are doing in the same OT or same instruments, then the chances of reinfection are very high. This was initially performed by endoclinic for infected total hip replacement. Freeman described it for infected TKR in 1985. The steps are explantation, debridement in cyclical fashion. Same debridement protocols have to maintain like in 2-stage revision, and then you have to do the reconstruction. So exposure has to be really extensive, where you can actually expose entire all 8 compartments, all 8 zones of the knee. You have to refreshen the edges of the incision, curate all the sinuses. You can do quadriceps snip if it is tight knee or TTO. But generally, if it's very tight, then my choice is do a quadriceps snip. You have to do thorough synoectomy, canal reaming, like in 2-stage revision. You have to be very careful in debriding the posterior capsule, avoid injuries to the neurovascular structures on the posterior side. So you hold a cutting instrument parallel to the posterior capsule. Don't make it horizontal. Some people, especially in endoclinic, when they are doing single stage revision, they excise the collateral ligaments also and always go for a hinge. I'm not using a hinge in all the single stage revisions, but I take out all the synovial membrane and all the unhealthy tissue over the collateral ligaments. And only if I think that the collaterals are inadequate, then I go for the hinge type of fixation. Once that is done, then you do a temporary closure, do dressing, relieve the tourniquet if you are using it, and then change to second OT, fresh dripping, fresh gowns, and then go for the debridement. This has been described, chemical debridement, in some papers, where I nowadays use very dilute chlorhexidine, keep it for about 8 to 10 minutes in the joint, After that, again, I give a thorough lavage and then go for a dilute 3% povidone iodine solution. Again, do a chemical sort of debridement. Hydrogen peroxide also has been described, but and I always use it. And some people don't like it, but there is no really evidence that hydrogen peroxide is of much superior result. But chlorhexidine and povidone iodine have better results. In reconstruction, like in any revision, restoration of joint line is of paramount importance. You can have various parameters. If it is elevated or depressed, then you will have compromised knee function. I measure distance from lateral epicondyle or from adductor tubercle and try to restore the joint line. So you have to use augments or sometimes, distalize the femur to get the joint line if there is bone loss. If the single stage, the exclusion criteria for are like systemically septic patients who are in toxemia, you should not offer them single stage revision. If there is compromised soft tissue envelope, there are the sinuses which are really adherent to the bone. You should not do a single stage revision. Primary closure is not likely to be achieved. These are not good patients for single stage revision. If you don't have a microorganism isolated, this is very important. You should never go for a single stage revision. If you have a microbe and you have a sensitivity, then single stage revision can be considered. If there are massive bone resection or bone loss is there, again, this is not a good strategy to go for a single stage revision. You have to let the infection get controlled completely with a spacer and systemic antibiotics and go for a two-stage revision. If there is a disruption of extensor mechanism, either on the quadriceps side or on the patellar tendon side, then again, you should not do a single stage revision. So this is a short video of single stage revision. You can see that this patient, we had actually isolated the organism and there was no draining sinus as such. On X-ray, there was slight lytic zone. Then we have started collecting samples right from the incision and start taking out the synovium. You can see I'm going flush to the compartment and try to excise it. So you have a very clear base. So all 8 zones, you take out the synovium. You have to take out from the retropatellar area and taking out all the diseased or bad synovium. You have to see the undersurface of the quadriceps tendon, that is quadriceps apparatus. Once that is done, then initial debridement is completed. And then I go for the implant removal. Poly is taken out. Again, you visualize some part of the posterior side. And like in the earlier video, I'll take out the prosthesis with a thin saw. I go flush to the implant. Once that is done, then widen this and loosen it with stacked osteotomes. Posterior side, I use a thin osteotome. You always rock the prosthesis. Don't try to remove in single shot. Otherwise, it will come out with a chunk of bone. You can see that there is hardly any bone loss. And same this thing that you take out the tibial base plate also, flush to the bone and flush to the implant as much as possible through the cement mantle, and then stack this osteotome. In this case, the tibia was a bit loose, so it came out quite easily. And then I take a saw and take a freehand cut about 1 to 2 millimeters with small osteotome, remove all the cement which is there. This is very important. Don't leave any cement inside the canal. And with a ronger, you take out all the fragments. With a curette, you would take out curette the intramedullary canal thoroughly. Once that is done, then I use a saw to take out the remaining adherent soft tissues on the femoral side. So this is again a freehand cut without any bone loss. And then even on the posterior side, go flush to the condyles here. Then I take a nibbler and pull the posterior unhealthy tissues. Once this is done, I ream the canal and take a provisional cut on the tibial side. So this is all the first operation of the single stage revision. So about 2 millimeters of the bone is removed. So that gives us a nice fresh upper end of the tibial surface. So you can see that all the unhealthy bone along with the small cement that is removed. Posteriorly, you can see very clean capsule. You can see the undersurface of the quadriceps. Then I measure the gaps, so in flexion and extension. So my strategy for reimplantation is done. Once this is done, again, I'll go for all 8 zones and remove whatever unhealthy tissue is there. So you have to go on doing cyclic repeated debridements in this. Then I give a lavage. Now I've changed the operation theater and I go for the second operation theater and then drape the patient again and then go for the reconstruction. The tibial preparation is standard. Then there is nothing extraordinary in revision. You have to first balance the flexion gap. I've used distal augments here in this particular case for restoring the joint line and hemivages on the tibial side. And then you see that the knee is pretty stable. I have not excised the collateral ligament. So this is a LCCK type of a revision implant. Patellar tracking is checked. And again, thorough lavage is given. So you can see a very nice, clean, debrided joint now and completely macroscopically, there is nothing remaining in the joint. Then final implantation is done. Once that is done, all the augments as per the plan, we do it, apply some cement intramedullary and then apply on the tibial side also. And then we are ready for the tibial implant as well. So we have put 2 hemivages on the tibia so that we cover the gaps and then use this LCCK implant, which is very stable now post reconstruction. So this is how you do it. And so this is this thing. So again, I'm again repeating this problem because debridement is of the paramount importance. Extensile approach, sinuses excise, all zones excise, biofilm excise. So this is standard for all single or 2-stage revisions. Single stage revisions reduce morbidity due to 2 operations and 2 anesthesia. The rehabilitation is shorter. The patient gets better knee function. And there is no statistical difference. If you stick to strict inclusion criteria for single stage, then there is no no significant difference between single and 2-stage revisions. So it's an effective treatment option. Debridement has to be done properly, and you have to consider as 2 operations done one after other. And antibiotic protocol remains the same for both. So thank you very much. If there are any questions, then I'll be happy to take it.
Thank you, Dr. Narendra Vaidya, for excellent lecture on prosthetic joint infection. I think there is a question in the chat box.
Yeah.
Can you see the question?
Yeah, it's what first, I don't have any experience about the biofire, so I cannot comment on that. When to decide dire or single stage revision? See, the dire is restricted only to immediate post-operative period, and if the patient is having immediately within say 7 days to 12, 2 to maximum 2 to 3 weeks, then I do dire. Otherwise, patient goes home after suture removal, and then patient is diagnosed to have a periprosthetic joint infection. Then single or 2-stage revision is done. So dire has got very limited sort of indication, and you have to be really very, very suspicious in immediate post-operative period. If the infection is for a longer duration, then dire is of it's of a very limited sort of a value. So go for either single or 2-stage revision. But single stage, choose your patients really carefully, and you must isolate the organism to emphasize again.
Dr. Pachore, can you just throw some light on biofire? Dr. Pachore, sir. Dhanasekara, you have biofire in your institute?
Yeah, it's done in the Ranbaxy center. We send the sample, they do the biofire testing. It's a PCR-based study. They have the panel of bacterial DNA. They match the patient sample. If they detect any DNA, they give the positive results. I think Dr. Rajeev also has some experience. He can also share his experience.
Yes, Dhana, Dr. Dave. The biofire, the biggest issue with the biofire is that it detects many bacteria which may not be pathological. So it's like many false positive results are there. So that's why initially we started using the biofire, but then we discarded this practice. And in the recent time, the last meeting on revision meeting in Delhi, Jawad Parvizi was here, and we discussed it at length. And he agrees that probably the biofire is not as useful as initially we thought it to be.
It picks up the dead cells also, dead bacteria
That's
also.
right. Yes, yes.
Hmm.
So that is why it is not really a big use for deciding about what is to be done.
Dr. Narendra, do you use antibiotic in the cement when you do 1 stage or 2 stage?
Yes, it is. I mix 2 grams of vancomycin in the cement. And I use a Genta cement, but in Genta cement also I'm using vancomycin 2 grams. And in addition, a second antibiotic, as if required in the cement beads, the calcium sulfate beads also I'm using. So if permitted, 2 antibiotics I'm using.
So for the benefit of fellows, can you explain what are the 8 zones you're talking about debridement?
So 8 zones are 3 above the patella, that is the medial and lateral parapatellar gutter. Then on the posterior side of the quadriceps tendon, then a posterior side of the patella. Then you go to the patellar tendon. There is a fat pad there, which in infection gets adherent or there is unhealthy tissue there. And then around the tibia on the medial and lateral side and on the posterior side. So these all 8 zones you should systematically go on debride in a PJI.
Yeah, debridement is one of the most important steps in treating a PJI.
Yeah.
Debridement is also very important. That's the first priority.
I think it's even more important than putting this thing a revision implant inside, and that can be done, but you have to take out all the debridement, all 8 zones. You have to debride it, give lavage, and again inspect it, because there will be always 2 or 3 times I revisit the zones.
Yep.
Dr. Narendra,
Yeah.
Not very common like a hip, but you think that tuberculosis infection may be suitable for 1 stage revision in TKR?
Yeah, I think if tubercular infection is there, then yeah, there's definitely you can consider that, and you have to start on the AKT. And in those situations, I have not tackled many, but tubercular as well as sometimes fungal infections also be there. So keep your watch on that, because the routine antibiotics will not help in these kind of situations.
Any role of antibiotic coated sutures in infection?
I have not used antibiotic coated sutures. I think some other surgeons will have experience about it, but I have not used it.
Rajeev, Dr. Dhanasekara, any choice that we should use antibiotic sutures in the this sort of cases?
Dr. Dave, I have no experience of antibiotic sutures so far.
I also not used, sir.
About the tuberculosis, I think it's a good idea that it can be done in the single stage. But one has to be sure about the tuberculosis. The other big issue in the infected joint is the culture negative infection. That's a very major issue, because you do whatever, but if the culture is not coming positive, in spite of taking 5 samples, including the sample from the medullary cavity, then you are in a big fix. So what is your advice in these cases? Which antibiotic you choose?
I'm using broad spectrum antibiotics, and I also give rifampicin because it has good bactericidal things. And I continue it for at least 3 months, the rifampicin in these situations.
And another addition in this is that that's what we discussed in the last meeting. Adding the antifungal also could be a good idea in these cases which are culture negative.
We are using amphotericin if the infectious disease specialist advises, but again, not in all cases.
Right.
So it is either VMC or VMA. So vancomycin or vancomycin amphotericin. In a culture negative, either it's a VMC or VMA.
Yeah.
So
Yeah,
always
that's very good way to remember. Yeah.
Yeah.
we
Dr.
send
Pachore,
Yes,
sir,
Narendra.
कुछ बोलिए.
Thank you. हाँ.
हाँ.
Thank you for the great lecture. 2 or 3 important things, Narendra.
Sure.
Just for the youngsters who have joined, what about the role of sonification? Sonification, are you doing it? And what are the things are?
We are not doing it actually, and I have not much experience about it.
Yeah. So anyhow, that's a good thing that those who are culture negative,
Yeah.
the sonification can yield better. Only problem with sonification is transporting the implant. It has to be absolutely, the contamination rate has been high. We have been using actually here, we do a sonification here at our hospital. So this is one of the things the youngsters should know. Number two,
Sir, do
very
you do
important.
it? Do you do the sonification in the operation theater itself?
No, we just collect
No.
in a sterile and we are the same wing. We operation theater is the second floor and the microbiology on the 7th floor. We just transport and there is a special other lift for this.
Right.
Yeah, Dr. Rajeev, further to add this, the only problem is that you should have a big sterile container
Right.
and you should not try to put any fluid like NS or ringle lactate. Usually they recommend ringle lactate, but they very strictly say that send it to us as early as possible. Do not try to contaminate with the fluid from the outside. So you should really have a big box, like a plastic box, which are ETO'd to put the implant. Otherwise, you will not be able to take it properly in a sterile. And those ETO boxes, directly that implant is put into that. And as Dr. Pachore sir said, mainly where there is a culture negative because of the biofilm, which can be taken out from because of the sonication, may give you better yield to find out if there is any organisms we can pick up.
Right.
Narendra, second one important thing, all patients, even after 6 weeks or 3 months, your ESR and CRP does not come to normal. Many, one third, almost about 20%. You have to go as a surgeon, as a clinically, the things are settled down, moments are fairly okay, the wound has extremely healed well, and there is no any signs of EA. So what is your take on that? Even though you are 2 weeks of antibiotic free, still the things are not settled down.
If there
How
is
long you can wait?
clinically silent knee and good healing, and there is a reducing trend of ESR CRP, then also I may consider to go in and do a second stage. But if they are remaining high, like 100 CR, this thing ESR and more than 30 CRP, then I'll be again considering to do a redebridement and repeat take more cultures and try to isolate the organism.
Do you aspirate the knee before going inside?
Yes, actually aspirate, but sometimes it can be a dry tap, and if it especially is the fibrosed and with a spacer inside, if there is very unlikely that we'll get a good fluid, and there may be compartments also where it may not be one single synovial sort of a cavity, and so I am slightly not very keen to put needles in multiple places. Rather than, if it is not settling, then I may go in and do a tissue culture or something like that.
I agree, because that's a very important point you have discussed.
Narendra, there is a second question. If you can see the chat box.
Yes. Arthrodesis versus repeated second stage. Now, arthrodesis, I'm using CAM in some cases where it has not this thing. I discuss the pros and cons with the patient if the infection is actually not completely eradicated, and or you can use external fixators in some cases where putting a CAM again may be a source of infection. But if the patient sometimes says that, no, I don't want to take risk of infection again, then these are the patients where they're not getting counseled, and definitely arthrodesis is considered. But I don't force arthrodesis on a patient. I give both the choices to the patient actually and give pros and cons. But you have to explain about 10 to 15% chances of reinfection even after a second stage of revision TK. If they are accepting it, then yes, repeat revision TK is done.
Can I, Dr. Dave?
Yes.
Regarding the aspiration, it's a good idea that where you have a dry tap, you can use the ultrasound guided aspiration. That is very helpful sometimes. And more so in the cases of the hip, because the volume of the joint is large. So sometimes there is an entrapped small abscess around the implant, and you can reach that abscess very easily with the if you do it ultrasound guided aspiration. Ultrasound first will diagnose that where the collection is, and then you can aspirate that.
Yeah, more useful in hip.
Yeah, more useful in the hip. Regarding the arthrodesis, do you think the arthrodesis itself is a very difficult procedure because there is a large gap?
Right.
So do you use the arthrodesis devices like Exatec?
Yeah, I am using this cam in such situations. Fortunately, I have not got an infection after using cam in this thing.
Recording in progress.
A cost factor also comes in picture. It's very costly for this. And already the patient is financially drained, then it may be a difficult choice. Yes, but most of the cases I have used cam inside for arthrodesis because these gaps, if you try to fuse it with the external fixator or sometimes Elizarov in very rare cases, then again there is a lot of shortening to the patient, and these are not very happy patients after arthrodesis.
Right, very right.
Narendra, external fixator is not good. These are
Not good.
very osteoporotic patients.
Right.
And we have faced almost quite a lot with actually this.
And
what you said is either use that or use a dual plating. That is the ideal way of getting the things done,
Right.
But the cam, we have also done a good numbers, and that's a good option. You can quickly mobilize this patient. They're
Right.
very elderly, they're fragile. And we consider orthodesis when the patient is fed up and surgeons both are fed up. So probably that is the time we have to think of getting orthodesis,
Right.
The elderly people will not tolerate many surgeries,
Right.
Dr. Dhanasekara?
Yes, sir.
Just can you summarize and thanks to Dr. Narendra, and then take over and introduce Dr. Rajeev. We are almost reaching there if there are no questions. Dr. Raja?
Yes, thanks for the wonderful lecture, Dr. Narendra. The videos are very informative, appropriate videos, and excellent points you have shared. So importance is identifying the bacteria and doing a thorough debridement. And based on the selection criteria, either we do single stage or two stage, and we follow up with the appropriate antibiotic. For culture negative infection, we give a broad spectrum antibiotic. So this is a nutshell. That's about the PJI. Now I would like to introduce Dr. Rajeev Sharma from Delhi, the chairman of the Orthopaedic department at Moolchand Hospital. And he is a very experienced senior orthoplasty surgeon with more than 10,000 joints. And he's going to talk about unstable hip. So it will be a nightmare if you do a hip replacement and it dislocates. So it is a challenging problem. He's going to talk about that now. Over to Dr. Rajeev.
Thank you so much, Dr. Dhanasekara, Dr. Dave, Dr. Pachore, for this great opportunity. And thanks ISHKS as well for the invitation. Dhanasekara, can you see my screen?
Can you go to the slideshow, sir?
Yeah. Can you see it now?
Yes.
Okay. Thanks so much. Yeah. So I've been asked to speak on this difficult subject of unstable hip, which itself a nightmare, as Dhana has rightly mentioned. It is a big nightmare for the surgeon and the patient both alike. It's a difficult problem because the patient and the family who are very, very apprehensive after the dislocation has happened, and the reputation of the surgeon is also involved. The majority of the dislocations occur in the early postoperative period. The reasons are whether they could be patient related, they could be technique related, and they could be implant related. And I'll just discuss in brief about all of them. Important points in the treatment are that approximately 2/3 of the cases can be treated by close or open reduction, and precautions thereafter considering that implant position is optimal. And we will discuss in brief about what is the optimal position for the implant. And 1/3 of the cases only will require the surgical treatment, that is the revision, including the constrained liners, elevated rim liners, dual mobility implants, or the old technique of trochanteric advancement. Like you see this simple arthritic patient. He had a reasonably good surgery done and immediately post-operative X-ray. But when you see this patient in this position, which is at 1 month post-operative dislocated hip, and that too under the effect of influence of alcohol. So these personal habits of the patients also are very, very important. And in this case, the good part was that patient family they themselves have accepted that patient had a massive amount of alcohol, and then he had a sleep, and during the sleep it just got dislocated. But these patients can be treated well after the open reduction. Like in this patient, we had to do the dislocation, the reduction under anesthesia. And then this patient had done very well, like 1 year follow-up, and now probably this patient is around 5-year follow-up, and there's no issue of the dislocation, and he has a excellent range of movements. You see this a problem which is a very difficult looking revision case where you have a severe problem of the cup. This patient was revised. This is about I think around 15-year back operated case. This cup used to be called the octopus cup, which is not used anymore. And this, if you can see here, this is the elevated lip liner. This was a cementless cup and cage, the older type, but it dislocated in 2 weeks' time. And this patient again had the open reduction. And after the open reduction, this hip was reduced. And you see the 7-year follow-up of this patient. So it is not like this, that if you have a dislocation, if the position of the implants is right, if the soft tissue tension is right, then there is no major worry that it is not necessary that you have to revise the implants. So let us understand what is the successful hip arthroplasty is, and I think it is very important to know that what should be our alignment and what are the basic precautions before we discuss about the surgical management of the dislocated hips or unstable hips. You must do the proper acetabular evaluation. Margins and peripheral osteophytes have to be assessed well. Floor protrusio, cyst, dysplasia, medial wall position, the femoral evaluation as well. What should be the neck cut level, what should be the distance of the narrowest canal from the tip of the trochanter, and offset is very, very important part when you are managing the hip. The primary surgery itself, you must try to replicate the native offset, and if you change it, then change it accordingly, understanding it very carefully well. Templating is very important, which shows the acetabular cup position, size, femoral cup position, component position and size. The cup position of 30 to 50 degree abduction is and 20 to 40 degrees of anteversion, and mostly it is about 20 to 25 degrees of anteversion, which is a very safe one. And anteversion is probably more important for the dislocation. So one has to be very careful about it. And that's what you see. The cup should be placed in this way. The influence of component position, as we discussed, cup anteversion is the most important variable for the risk of dislocation of the hip joint. Position should be right, whether you are using the anterior approach or the posterior approach. Measurement of the vertical and horizontal offsets is very important. And here, what I do is a simple trick of making a hole in the lesser trochanter, a hole in the greater trochanter, and just measure the vertical offset and horizontal offset. This is one thing which is very, very reliable. And you can see after you have put the implant, you can cross check that what has changed in that vertical and horizontal offset in the before you started the replacement and after the implantation. Neck cut level should be assessed very well. Neither the neck cut should be too high or too low. Acetabular exposure is very important. If you have a 360-degree view of the acetabulum, then most likely you will place the cup in the right position. Final reaming and cup placement is very important. You must ensure that the cup positioning is very right, especially the anteversion. Osteophyte removal, because osteophytes can cause, especially the anterior osteophytes, they can cause the obstruction, and that they may be the reason for the dislocation. Coverage, that should be the coverage, the combined anteversion. And the soft tissue tension is very important, that how much should be the soft tissue tension in the patient. You should just have about 2 to 3 millimeter of laxity, because patient is under anesthesia, and when he'll come out of anesthesia, that muscle contracture will also reduce rather increase this tension. The capsule closure, if you are using the posture approach, you must ensure that the capsule is sutured to the bone. Now, the surgical management of the unstable hip, if you have a persistent instability following the non-operative management, then probably component malposition has to be assessed well. Algorithm for the surgical management is, if the implant is in malposition, you need a revision for sure. Optimal positioning of the cup and the stem, you may use the large diameter head and you may use the DM cup. If the implant is in good position, and there is an impingement, you may probably go ahead with the modular exchange, the longer neck, large diameter head, or the lipped poly. If you have an abductor dysfunction, then you can manage it accordingly. If there is a laxity, you can use a longer neck or trochanteric advancement. If there is a non-union of the trochanter, then you can reattach it with addition of the DM cup. If it is incompetent, probably you have the options of using the constrained cup or a DM cup. Or the dual mobility hip arthroplasty is very useful in these cases. Modular component exchange usually reserved for patients who do not have a gross malpositioning of the components or abductor dysfunction. Increasing the length, increasing the femoral head size, using a lipped or antiverted or lateralized acetabular polyethylene liners may be a good option. Many modern implants are designed to decrease the anteroposterior prominence of the neck of the femoral component. Larger femoral heads and redesigned femoral necks, they improve the prosthetic stability by increasing the head to neck ratio, resulting in an increased arc range of motion prior to the impingement. And larger femoral heads also lead to an increased excursion distance and subsequently reducing the risk of dislocation. With an increase in the head-neck ratio, there is an increase in the range of motion prior to prosthetic impingement, and that is a very useful trick for the safe hip arthroplasty. And head-to-neck ratio, higher is the better, and most of the knee hip implants these days are having a good head-to-neck ratio. Extended offset in deserving candidates, probably an extended offset can be used. You have the many implants who have the option of the extended offset with the increasing size of the femoral component. Jumbo femoral heads, larger femoral heads are, they may travel a greater excursion distance prior to the dislocation. So there is a difference between the small size and the large size. Mostly the diffuse jumbo femoral head, which was the anatomical head, was a very useful device. This was mimicking the BHR cup, but unfortunately this has been withdrawn from the market these days, which is the delta motion hip. This was the ceramic on ceramic articulation, and using the anatomical head was a very useful tool. Elevated rim liners are used as their asymmetrical configuration provides added support in regions of greater instability if placed in the posterior superior position when performing a posterior approach, especially for the posterior approach of the hip. Constrained acetabular components, as you can see, are a useful tool, but only limited for the use in the patients like the elderly population, where you have a patient-related factor for the instability, and also in cases of the incompetent abduction. Constraint liners could be the cementless or could be the cemented, should only be used as salvage procedure in elderly or a low demand patient with the hip instability. Better avoided in the high demand revisions, component pull-out is a serious risk prior to the achievement of the ingrowth. The failure mechanism in constraint liners is by the cup loosening, failure of the locking ring, or the polywear. We'll see some of the examples. Constrained cups appear incapable of meeting the demands of the revision total hip. Especially in the high demand patients, the polywear is very common. Let us see the example of this example of a 78-year-old patient where the 6 months after failed dislocation of the hemiarthroplasty patient presented, and patient has been walking on it. So this was a difficult situation. The hip implant itself was placed in the mal position. This did very well using the cementless constraint liner and a revision of the femoral component to a longer cemented hip stem. Another example where you had the patient with a trochanteric fracture. Now this patient was initially treated with the hemiarthroplasty, bipolar hip arthroplasty. And this patient at 2 weeks' time was doing excellent. But he had a fall at 1 month post-operative and dislocated his hip joint. Looking at his age and avoiding we have reduced it twice, but later on we converted this to a cemented constraint liner, and trochanter was fixed again because we did not want to go for the third surgery for this patient. But unfortunately, same patient had a recurrence of the fall and he had a trochanteric fracture on the right side. And then we had, instead of waiting, we went ahead on the right side also with a cemented constraint liner. And patient did very well post-operative at 2 years. Of course, he had the severe osteoarthritis of the knee joint, which was making it difficult for him to walk. And that's what patient is at 3 years follow-up. Bilateral cemented constraint liner. Another example where you had a shattered proximal femur and it was also added infection. This was a dysplastic hip treated primarily with the hip arthroplasty, and there were no subtrochanteric osteotomy as we imagined in this patient because the proximal femur got shattered when the surgeon was trying to reduce and trying to push the implant, the femoral stem, more distally. Because of the infection, we had to treat it in the 2-stage revision. And after the 2-stage revision, we used the tumor prosthesis with the constraint liner. And that's what you see. This patient walking at 3 months safely. You see the 3 months mega prosthesis with a constraint liner. See this patient at 5 years. Doing reasonably well. This patient is still under follow-up. So as such, the use of the constraint liners should be avoided in cases involving the acetabular shell revision, as subsequent stresses may lead to component pull-out prior to the achievement of the ingrowth, which can be a major issue. Dual mobility bearings probably is a very, very good option. And in today's time, if we have a similar case, probably we'll use the dual mobility cup instead of using the constraint liner. A retrospective review of the consecutive series of dual mobility performed in 151 patients deemed to be at a high risk of suffering from the dislocations reported a dislocation only in a single patient. So DM cups are probably very, very useful to manage the unstable hips. Trochanteric advancement, this is the old technique. This technique improves the resting length and functioning of the abductor mechanism, thereby affording the hip greater stability in all up to about 90% of the patients. One very good example, the serial X-rays in a follow-up showed progressively increasing osteolysis, and this is the solution stem, and we know that solution stem could be a major issue because this has a good ingrowth in the stem. And this patient, we had the proximal osteolysis because there was a stress shielding, and which went on to dislocating the hip joint because of the whole abductor mechanism inefficiency. Later on, this patient had a breakage of the solution stem, and we used the mega prosthesis, reattachment of the abductors to the prosthesis. And this patient did well at a follow-up of 1 year. Constraint liners, are they a guarantee for the stability? Now that is a major issue, and I think this is a very important case that we will discuss. This patient, we had a total femoral replacement, and because at that time we did not have the dual mobility cup, so we used the constraint liner at that time, and we can see the post-operative 2 weeks with a healed surgical incision. Patient was doing well. 2 weeks post-operative, patient was doing excellent. This is at 5 years. Patient was doing reasonably well, was able to walk without the support, was able to walk much better with a simple support of a stick. At 5 years and 3 months, this patient had a small fall and he dislocated the hip joint. When we opened up the hip joint, the liner ring was broken and a significant polywear was there because he's a young patient and he probably was using it more than what he should have been using. So we did we revised it. We did revised the ring, and patient is doing excellent after that. Failure mechanism in this constraint liner was the failure of the locking liner ring. So can dislocation of a constraint liner be salvaged with a dual mobility? Yes, probably a dual mobility constructs are a better option, even in cases where you have a failure of the constraint liners. So the take-home message is not every dislocated total hip replacement will need a revision. You have to assess it well, as we discussed. Large diameter heads are useful, but you can plan 32 millimeter or maximum 36 millimeter heads. Dual mobility implants are expected to improve stability, and constraint liners are a good choice for a sedentary or the elderly population. So the unstable hip is a major issue, but it can be managed well. But it's very important is that you have to assess the reasons why the hip is unstable, and then you can plan the management accordingly. Thank you so much.
Thank you, Dr. Rajeev. It was a wonderful lecture covering a difficult topic.
Thank you, Dhana.
Dr. Rajeev.
Yes.
Do you think that what we have been taught and what we know that the dislocation is common after PHR in fracture neck of femur patients? So is it always better to use a dual mobility, or in all the cases, would you put that message? What is your point? Take on, and then we'll ask Dr. Pachare also, because this is a very common problem which
large
we see.
Experience, right? Before Dr. Pachare gives his opinion, I'll just mention one thing. That fracture neck femur, we have to understand that the capsule of the hip is normal. The capsule is not a contracted capsule, unlike in an arthritic hip, where you have a capsule which is contracted. So the contracted capsule gives some kind of a instability. So that is why the fracture neck femur patients are probably more prone to have the dislocation. That is why probably you very rightly mentioned that you have to be more careful in fracture neck of the femur regarding dislocation. And what is important is probably the right offset and right length and right soft tissue tension. Regarding the use of the dual mobility in all fracture neck femur, probably my view is that probably it is not right unless you find that you have used all possible techniques of maintaining the horizontal offset, the vertical offset, the right kind of the soft tissue tension. You are not able to achieve. Probably in those cases only you may resort to the dual mobility. So in short, for our younger colleagues, probably a dual mobility cup may be kept ready if possible. And Dr. Pachore's opinion on this will be very, very important. Yeah.
I think there is a burning question for everyone. I think fracture neck, you have to actually see whether the patient was active before or patient was not active. So that is a major difference you have to those who are community ambulator and non-ambulator. So the whole difference is different. Number two, you have to see the neurological status. Those who are Parkinson and other places, they are in a separate group. So you have to divide them separately. Very elderly, around 75, 80. My approach for this, most of the patients are, we use the anterolateral approach. We don't use any posterior approach for fracture neck femur. And second important thing is, you can lengthen the little bit, half centimeter or more little here. And what Rajeev says is very important. If you are doing a posterior approach, the capsule usually is virgin. And that's why it is very, very lax. And olden time, Ranawat described very well. What he described in this fracture neck was, use larger head, put at least a 1 centimeter length can be, you have to tell the patient that you may be a little longer. Use a posterior lip liner. Keep a cup more than not 45 degrees, maybe 40 degrees, and anteversion slightly more. And use high offset for these patients. And that is another important thing. So I think we don't do dual mobility for every fracture neck femur. I agree with Rajeev. These are very active patients who are active patients. Maybe we can consider that for dual mobility. That is what we look at it. And very elderly, we are absolutely ambulatory. I think straightway whatever you do is okay for them.
Dr. Pachore has rightly mentioned that keep it about 40 degrees. My trick for putting the cup is that I keep it at 45-degree angle, which is easy for my eyes to assess, and then I reduce the angle by about 2 to 3 degrees. Now that way I am able to assess well that I am keeping it less than 45. And also I use the aligner. I attach the aligner to the reamer. And that is a very useful way, because if you ream in the right direction, you will be able to place the cup in the right direction in a much easy way.
Rajeev, this is for young people who have joined. Probably because of the lecture was too extensive, you could not cover 2 or 3 important. Probably you can cover right now. What about the TAL and the regarding the TAL and your anteversion, whatever, so that you can tell the youngsters what you look at that. And number 2, the lot of work and lot of, I think, hype regarding spinopelvic parameters. So 2 things you can just give a little glance to the youngsters.
Thank you, sir. Very rightly mentioned that TAL is very important. And when you are having even for the experienced surgeons, probably the TAL is still important, because the TAL will remain available to be seen even in the fused hip cases. The 2 aspects are very important: the TAL, the anterior and posterior margins, the surfaces, how much the osteophytes, and also the medial wall. You may ream up to the true base of the acetabulum. You need to be sure, like I mentioned, the trick of assess it to 45 degrees of abduction and then reduce it by about 2 to 3 degrees. Make sure that the cup is parallel to the TAL if you are able to assess the TAL well. And my trick is to have the proper view of the TEL is that one pin superiorly, one Holmes retractor as anterior superior lip of the acetabulum, because the anterior superior lip of the acetabulum is much more stronger than the anterior lip. So keep the bone lever at the anterior superior lip and a large retractor on the posterior parts, the posteriorly, and one Holmes retractor just at the teardrop. So that you have a clear view, 360-degree view of the acetabulum, and you are able to have the direct view of the TEL. And make sure that you don't damage the TEL when you are clearing up the acetabulum or the floor of the acetabulum. Regarding the spinopelvic assessment, especially in the fused hip cases, is a recent learning. And Dr. Pachore, there was a very interesting webinar with the British Hip Society, where the surgeon, one of the surgeon from UK, spoke about the spinopelvic measurement is very important. And I was given the topic of that in the older time, we were doing all these fused hip cases, and what was our assessment without having the spinopelvic assessment in the fused hip cases. And interestingly, the fused hip cases, they have the one very important thing, that they have a relatively less mobility. They have the relatively more contracted soft tissues. So the dislocation was not very common in the time when we were not having any assessment of the spinopelvic parameters. But yes, with the present knowledge that we have the stuck sitting and stuck standing cases, probably there it is very important to have the right orientation of the cup.
Dr. Pachore, you said
we discussed this with Vijay also in the last meeting of the revision at Delhi. That he also agrees, and we all have this experience that earlier when we were having no assessment of the spinopelvic parameters, the dislocation rate was not as high.
And I agree, Raju, because we were doing ankylosing spondylitis patients. Their demand was low. Was low, and what you exactly mentioned. This is my thesis in 1987. This range of motion, they have not what is called impingement level is not there.
Right.
So that's why there is a chance of dislocation for these patients are on the lower side.
Right.
Number two, you mentioned, I'll say very clearly, there's soft tissue, there is no resilience.
Right.
And that's why they're all, this is a pathological soft tissue. And that is the only reason they have a low rate of dislocation as far as I can say. But one important thing we mentioned from Suryaban paper.
Yeah.
He had a 3 out of 54 patients, he had a 3 anterior dislocation in spite of using posterior approach. And he is the first man to tell the world that there is you will have to reduce anteversion in the patient. If you have a kyphotic spine, you reduce the anteversion, and if you have a lordotic spine, you might maybe increase the anteversion. That was one of the best papers we had.
I think, Dr. Pachore, what you said, out of the whole subject of this, the one line which you just said, that if you have a kyphosis, you reduce the anteversion, and if you have lordosis, you increase the anteversion. I think that is probably the crux of the whole thing which we need to keep in mind.
Right.
Is that correct?
Very right.
So there are so many other things, but these are practical points, what we put it. One thing, Rajeev, regarding dual mobility, I do agree whatever you spoke. Only patients who do not have abductor mechanism and you can't reconstruct, dual mobility does not work. It is the only option for you remain is a constrained liner. Dual mobility again will fail.
Right.
It will dislocate.
Right. Dual mobility, I agree with you, sir.
Required for dual mobility. It
Dual
does
mobility
not work without abductor function.
Is not 100% guarantee. Yeah, I agree with you that the constrained liner is a good option in these cases, right?
So there's a question in the chat box. Boot bar application after reduction of hip.
Well, the boot bar is a relatively my opinion is that in a sort of boot bar, if you make sure, because the most of these dislocations happen when the patient is asleep. So if you use the abduction pillow with the strips attached to it, and that keeps the leg in abduction. All right. And at the same time, the mobility of the patient on the bed is not so much affected, because we need to see that the two aspects. One is we have to provide the protection from too much of undue activity. At the same time, we also have to protect the patient from the deep vein thrombosis and embolism. So I think if you want to protect the patient from embolism, you have to provide some kind of activity. So in my setup, probably instead of boot bar, abduction pillow with the strips attached, which are sort of holding the patient's leg temporarily, which the patient can remove when he wants, and a proper education to the patient and the family is probably very important.
We give a sort of abduction brace, which will control both adduction, prevent adduction and rotation. So that might be a better option. Patient can use it and be ambulant also, instead of putting a boot bar, derotation boot, what we call it, boot bar. That will cause a lot of problems with the recumbency. Patient will develop a bed sore. They'll develop a sore in the heel. So we don't
That's
use.
right.
Dr. Raja, little loud.
Yes.
Dhana has mentioned that the abduction brace is very useful in his setup. Dhana, can I ask you that the abduction brace we did use for some of our patients, but our patients found it very cumbersome to be used. Do you think that's right?
So that's while walking they use it, sir. When they're bed, as I said, they put a abduction pillow.
Pillow.
Abducted. When mobilizing, they use a brace. It gives more mental support, and it prevents unnecessary movements.
Right.
It's cumbersome, but patients get used to it.
Right.
Rajeev,
how do you provide this brace?
They make it custom made. The orthotic people take measurements for the individual patient.
The duration?
Probably for 1 month to 6 weeks.
1 month. Yeah.
So nowadays, they don't require to customize. There are now available of various. It is available.
Yeah, ready-made.
One thing, Rajeev,
Sure.
I learned from Hugh Cameron that you just keep a pillow in between and keep the knee brace, so that they don't flex the knee. So that is the most important thing which is there. Just a trick we learned from Hugh Cameron.
That's very right, sir. That's a very interesting trick, and we use it in patients who are not very good, who are not going to follow our commands well. We give a knee mobilizer in addition to the abduction triangular pillow. Right.
That's right.
That's a very useful trick, actually. Because the most dislocations will happen when the patient is bending the hip. And the bending of the hip is with the bending of the knee. Sir, another thing small trick that we use is that we tell our patients that they will not wear any trousers for a period of 1 month. And they will wear something which is overall. So that they will not, in some action of wearing the pajamas or pants, they may commit a mistake. So that's another one small trick that we use.
So they have to become South Indian style dhoti.
Yeah.
Like Raja.
Actually, yes.
Rajeev, one more question. You said that the first time dislocation, we reduce them.
Right.
How long we advise them the rest?
We do it, Dr. Way, for a period of 1 month.
Okay. You mean complete rest?
I give it if the patient has a dislocation, then I keep it on a high risk patient category, and I ensure that the patient remains on the bed for a period of 1 month, and then a lot of counseling to the family that they will not allow the patient to commit a mistake again, and provided our implant orientation is right. If the implant
No,
orientation...
that's true.
Right.
But Dr. Raja, what is your protocol? Would you just keep them for 4 weeks, complete bed rest for the soft tissue healing, whatever disruption of the suturing, whatever we have done?
So if we have dislocation, the early post-operative period, I think better to immobilize. Otherwise, there is a high chance of redislocation.
Right.
If it is the old case where there was a trauma or patient had dislocated, if there is a they are squatted or cross-legged, then we can need not immobilize for 1 month. We just examine the patient under anesthesia. If the range of movements is good and there is no instability, we mobilize them immediately. But early post-operative period, better to immobilize for 1 month. Allow the soft tissue to heal. Or we, as we discussed, we give a abduction brace and abduction pillow, and then we mobilize only limited ambulation within their room, and we mobilize for 1 month. We not allow them to use a sit-up. That's the main restriction we follow. Otherwise, they are ambulant with the brace. This is not a complete bed rest.
And out of the way, one more thing, if I can say, that the patients who are cachexic, who are very weak musculature, very elderly, who are not expected to follow your commands verbatim, or sometimes you also have the relatives who are not able to sort of understand the things very well. In these cases, we ensure that the patient is using, as Dr. Pachore has rightly mentioned, the knee immobilizer. So patient can walk, patient can do all other activities, but the knee immobilizer to be used, because if the knee immobilizer is there, then patient is not going to have the flexion of the knee and the hip. So that remains a protective technique for us.
I think one more last question to you, Rajeev. How many dislocations you would consider before you decide to say close reduction? Sorry, that now it's okay, 2 or 3 that we should now go for a revision.
Well, if it is more than one dislocation, and you have to have a very closer look at your implant, and also when you are reducing it under anesthesia, see that how much soft tissue laxity is there. Right? If you have a lot of soft tissue laxity, then you know that this patient is going to have he may have a dislocation again. So probably after 1 or 2 dislocation reduction, we should have a clear assessment that we are not, there is something we are not doing right. And probably in those cases, you have to revise.
Yes, sir. Yes, sir.
Post-traumatic dislocation, you can keep for 2-3 weeks. But if they are recurrent, you don't need it. This capsule never heals.
Yeah.
Never heals. Number 2, under anesthesia, Rajeev, you will always find there is a laxity. That is not usually the cause of the cause. You all discussed initially. Most of the time, it is the component. That is one you have to look into. And if there are more than 2 dislocations, you should start thinking. And one important message: unless you know the cause of the dislocation, it will never get succeeded. You will never be successful.
Well, very right, sir. The more than 2 dislocations should be enough to sort of you have a right assessment of your implant positioning, and more likely is that there is some malposition of the components, which is the reason for the dislocation. Right. Very right.
Examination under anesthesia is very important. After close reduction, we examine the hip through normal range of movement. If you're dislocating, in that situation, it's going to dislocate post-op. No point immobilizing and putting the patient under bed rest. So if there is a problem, intra-op examination under anesthesia, we need to address the problem. Maybe revision at the stage later will be a better approach rather than trying to immobilize and trying to get the soft tissue to heal and support it.
Right.
And we all get a CT actually done after the reduction. We always get a CT done before they are discharged. So at least we know 100% what is the component position, both femur and as well as for the acetabular.
Very
That is
right.
very important message for all the youngsters.
Because the
Any
dislocation is very, very disheartening experience for the patient as the surgeon both. So one has to assess it very well and be sure that you don't have a second such occurrence. So for that, Dr. Pachura has very rightly mentioned that the family and the patient have to be counseled, and we have to prepare ourselves very well with a good CT assessment of the hip implants.
And my boss last statement, Dr. Dholakya's statement. Can I?
Yes, sir.
If any surgeon says that he didn't had any dislocation, there are two things. One, he has not done enough numbers, and number two, he's pulling.
Yeah. Very,
So
very,
everybody has we do have.
yeah. Very well mentioned, sir.
Dr. Raja, can we just sum up now? You can thanks and take up the further things. Yeah.
One more issue, the option of soft tissue reconstruction, gluteus maximus transfer for reconstructing the abductors. Have you any experience with this, sir?
Yes, I have done 2 cases of the gluteus maximus transfer, and this is not a very difficult technique. In fact, it is relatively easy, and you have to ensure that the transfer that you do, it has to have an attachment to the bone with the help of ethibond sutures and roughening up the bone a little bit. And in fact, we make in both these cases, we made a small trough in the trochanteric tip with the high-speed burr and put the muscle into that so that it has a good attachment to the trochanter. But that's a very useful trick, and then very few cases will need it, but probably if you are doing enough number of cases, then some cases you will have to do.
So I had experience of doing gluteus maximus transfer in 2 patients. And one patient where there is complete loss, I used allograft, bone tendon bone graft, and one side I used the bone to attach on the trochanter, and other side I sutured to the residual gluteus medius tendon. So I think that is one useful procedure. Though they may not regain gluteus maximus medius power, it will act like a check-in and prevent dislocation.
It acts as a check balance, basically. You're right. Yeah.
So thank you very much, Dr. Rajeev, for sparing your time and enlightening us on the difficult problem of unstable hip. And thanks, Dr. Pachore, joining and giving your comments. And I thank Dr. Dipak Dave, my colleague and education chair. The next meeting, probably we are having, the ISHK meeting will be on January 11th, which is a Saturday, the second Saturday in January. We're planning to have the meeting on January 11th. And I thank the ISHK board, Trustee Dr. Vikram Shah, and President Dr. Indrajit Sardar, and all the team for the excellent opportunity. And I thank all the speakers today. And we'll join again for the next meeting on Jan 11. Thank you very much.
Thank you so much.
Thank you.
Thank you, Rajeev. Thank you.
Thank you so much.
Recording stopped.